So usually if you want to talk to my guests here tonight, you have to, number one, have a referral, and number two, have an appointment, but not tonight. We have Dr. Ken Schneider and Dr. Sindhu Kanjakal with us here to answer any questions you have about the patient-oncologist relationship. So are you ready?
We are ready.
Ready. Welcome everyone to Cancer Center Live. I'm Allison Johnson, Manager of Communications here at Windsor Regional Hospital. And if you've been to the Cancer Center ever, you may recognize our two guests here this evening. So we have Dr. Ken Schneider. He's been an oncologist in Windsor for 26 years?
26 years. Yeah.
26
Came back to my
years.
hometown.
Well, thanks for joining us tonight. And we have Dr. Sindhu Kanjakal, who a little less than 26 years.
A little bit, yeah.
But many years of experience.
Absolutely. And welcome to all of you. Cancer Center Live, as I mentioned, is an interactive and live discussion. So we hope you'll join us for this conversation tonight. Again, we're talking about the patient and oncologist relationships. So anything you want to know about how these guys prepare when you're coming in for a visit, what they think when you bring up things that you found on Google maybe, or how to approach if you would like a second opinion. So all fair questions for tonight. I do want to say though, before we get started, what we're not going to talk about tonight is anything medical related. These guys talk about that all day. So right now, if you have any concerns about your own medical condition or issues, for that, you still need to make an appointment. Deal? All right. So first question for the two of you. You've been doing this, I did a little bit of math, and I think for a combined total of 4 decades. Can you go to the grocery store or to your children's school without seeing somebody that you've sat down with in this room?
Well, that's rare. You usually come across someone, right? And it's almost like you know it's likely to happen, and it's a question of you want to be respectful of the circumstances if you meet someone out in public and, you know, greet them appropriately. And it's interesting where the conversations can go sometimes. Huh?
You know, I live in Tecumseh, so I'm a Zayres shopper. I tend to run into folks there, and usually, you know, I'm from a small town anyway, and to be honest, it's one of the things that I kind of enjoy about practicing in a small, we're not a small place, but a smaller community where you're likely to do that. So I think that that's a relatively common occurrence for many of the docs in the city.
I was talking to Dr. Ham the other day, interviewing her for a video that we worked on, and she said, in Windsor, it's like you're always treating family, because if you don't know this person, you know somebody who knows them. Mm-hmm. What's that like?
So I think that there's both the benefits of it, because there's always a connection I think you can make with folks that you have other connections with. Mm-hmm. But there's also the chance that maybe you will, I don't know how I would say that. In general, it's a very good thing, I think, because there is the intimacy, there's the opportunity to connect with other people in that circle. Mm-hmm. It's a good thing, yeah.
And what about privacy when someone comes up to you? Is that ever a concern or an issue, or how do you deal with that?
Yeah, that has happened many times where you're in an environment or circumstance where you're out with maybe someone in your family, and you come up and meet a patient, or they greet you, and you don't quite know how to react, because you want to keep things confidential, and you don't know if you should introduce them as a patient. So I usually allow the individual to make that first move and introduce themselves, and you know, most of the time it's never an awkward scenario.
Yeah,
you
and
just
then
have to let it play out.
they can set the ground rules, and
yeah.
if they're okay with everyone knowing
Mm-hmm.
you treated them. All right, so when people come and they meet you for the first time, when you're just starting your relationship with a new patient, what's that like when people enter this room for the first time?
You know, I think when I first started to practice here, one of the nurses that I would work with regularly would say that the consult was often the toughest time.
The first
The
meeting.
first meeting. And then, from a physician point of view, sometimes that's not true in terms of, the time you take, because many times you're collecting the story, you know what needs to be done, and you're setting a plan. But after a few years in practice, I started to understand, I think, what she was getting at, because that first consult, that first time in the room, is usually when, that person's life changes completely in that moment, and you're part of that. And so it's a very, I think, important moment, because it sets the tone for your relationship going forward. It sets the tone for how you're going to develop your relationship with all of with the many turns and challenges you're going to have as you go through.
Dr. Schneider, I know you have to go to school for very many years to get to wear the lab coat that you're wearing right now and get to see the patients. How much time do they spend in school when you were there talking about the communication portion of it?
Well, I think it's much better now. From what I've seen from the current curriculums in medical schools, they do really pay more attention to that dynamic of building a relationship with the patient and the interaction style. And, there is some formal teaching around that. When I went to medical school, not so much, even though, there was scenarios that you're evaluated in, either with simulated patients. I went to McMaster University, and, early on you have simulated patients to train with, and you can learn a lot from that, because you've got your future colleagues watching you interview a patient, and you can really learn a lot about yourself and how you interact with a patient if you look back on that being captured on a video. And I think it's an important skill that we all continue to develop, and you learn from your experiences, and you learn what you've done good, and you've learned what you haven't done very good, and hopefully we grow with that.
Do you think that you're much different now than you were with the first patient that you met in your career on that first consult?
I think intrinsically, no. I think there's a huge component of a person's personality that doesn't change. But I think the way you maybe read a patient and try to connect with them on a level that they understand is really important. This should not, an interview with the patient should not be scripted. It's real, and it's a breathing, living thing. And you have to really get the cues from the patient of what they're understanding, where to back off in terms of, is it too complex a discussion? There's a lot of things you have to read about the patient that makes that interview the best that it can be.
What about you? Do you remember some of the earlier discussions when you were just starting out?
Yeah, for sure. And I would maybe echo Dr. Schneider's point about how things have changed in medical school training. We're both professors at the university as well, and have the opportunity to interact with students. And I teach the first year students, and they do this really interesting course called Portfolio and Reflection, where they're actually learning to take the time and get into the pattern of thinking about, their interactions with patients and how they've behaved, their interactions with other colleagues. And I think that just raises an awareness that I know going through medical school I probably didn't have until much later. And I think Ken's right. As you go through your practice, you certainly, every single interaction I learn from, every single one is a little bit different, and you kind of build kind of a sense of maybe how you can be more empathetic, be more present, be more understanding of what a person's real underlying fears and questions are. So that's something that I think I've learned over the years and has helped me.
Great.
Maybe one thing that I could add is it's not uncommon that we meet a patient with a number of family members. And that can be a bit challenging, because you want to be respectful of the whole group that's in the room. And sometimes that goes well, but sometimes it can be challenging because you don't quite know who to focus on depending on who's more interactive in the room. And I've learned from that, because sometimes what's happened is, rather than discussing something directly with the patient, I believe eye contact is very important, and you're not looking down at a chart. Those things are important, or at a computer screen. And I've actually, something's been brought to my attention before where the patient said, you're talking to me, right? Not my family member. And you had to shift the focus. And, I think we have to be aware of that you're there for the patient, but you have to be respectful of family and answer those questions as well.
And I want to bring some of the audience members into the discussion now. Charlene Cowan had put this comment online prior to the start of the webcast. She said, over 20 years ago, I had regular appointments with Dr. Schneider. At every visit, I felt like I was his only patient. He always took time to answer my questions and included my husband in every discussion. And then she says, since then our paths have crossed at fundraisers, community events, etc. Kudos to a great doctor and a great person. So thanks, Charlene, for the comment. And
know her well, and Doug, her husband, absolutely.
And she talked too about talking to her husband. So you don't want to exclude the family member. You just have to. How do you find that right balance then?
Mm-hmm. Yeah, it's a question of that interaction and the dynamic of the discussion.
Is there ever a time where you feel like the balance is kind of out of whack and you've got to rein it in terms of, do family members ever ask you to go maybe beyond what you would feel comfortable doing?
I don't know if it's that. I think in a room there's so many different, sometimes emotions and concerns, and sometimes some family members are worried about what their loved one is going to hear. They want to be protective that way. So you do have to try to read the situation as well as you can, understand what each family member's maybe major concern is, and then when I do feel like maybe I'm kind of shifting my attention too much, I'll try to go back to the person in front of me and say, listen, do you have any questions? Do you understand this? And then give them the opportunity to be the main player in the conversation again.
Another part of this, if I can mention, is respecting cultural norms too, because you meet with a lot of different cultures, and I think it's important. Every physician might have a bit of a different take on this in terms of what that conversation should be in the information that should be relayed. But I think it is important to try to respect cultural values and norms, and the context of the discussions need to take that into consideration as well. What do you talk about? The fear of the word cancer. That's very common in some cultures, that you don't use that word.
You don't ever say it in the cancer center.
Yes, yeah. And so how do you get around honesty and the discussion that you have to have while respecting that? And there's a way to do it. There is a way.
How would you do that?
Well, I know how I do it, and everybody might do it a little bit differently, but this is where you respect that families might have questions to ask before you go in the room. And I know that can be a bit contentious, but it sets a dynamic that's correct, rather than you going in and families are rolling their eyes saying, don't go there, don't say that, because that's never good, in my opinion. So I think it's sometimes worthwhile to interview the patient, but understand that the family's there to support their loved one, and you have to take that into consideration as well.
I think also there's a evolution in those kind of relationships. At the beginning, maybe there's a real, hesitancy to be maybe too overt, and then as the relationship develops between you and the family member and the patient, it becomes easier to talk more openly, I find, because it's really an evolution of your relationship over time.
What's the best way to build that relationship? So I'm a patient and I'm coming in here and I really want to build this relationship because I know that we're on this journey together for the next little while. What advice do you have for people out there, in order to make this the best possible relationship for the journey?
I think, again, every interaction is different and depends so much on the personality of the person in front of you, and also with your physician as well. Ken and I are one way, but you're going to reach. There's so many different oncologists that you may meet. I think the general themes would be openness on both of our parts. So if you're trying to relay what's happening to you as you're going through treatment or something, being as open and honest about the symptoms you're having helps me to help you. And in general, physicians, we want to be problem solvers, we want to make things better, and so when we get that opportunity, we feel good, and that helps with those relationships. And I think just being ready to, I know Ken and I probably practice the same way, and I think you'll find that if most of the oncologists, the more straightforward you are, if you have a question even about a treatment decision or something, just speak openly. All of us know that this is not about us. It's really about the patient and what you're going through. And I think the more open and the more clear our conversations are, the better.
I think sometimes to acknowledge that these are difficult conversations. It's almost like practicing some mindfulness, that you're aware that if you were sitting in that chair or were on the other side, that these are very anxiety-provoking times when you come into a cancer program, and it's a new experience, and there's anxieties and high emotions and the fear of the unknown. And I think if you acknowledge that up front and say, we understand that this is something you've never experienced before, it just takes the edge off. That's what I found. If you acknowledge that.
So it's like a balance, the discussion between the clinical and what's happening, the reality. Another comment here, this is from Francesco D'Annunzio, and thanks for joining the conversation. And he says, when I was going through my ordeal with cancer, I felt very good to see Dr. Cangical. I did not feel like another number. She made me feel that I was a real person, and thank you, Dr. K. So I think that just kind of adds to what you were saying about making it real and keeping the discussion, but also the listening part too, right? I remember hearing somebody say, it doesn't matter to me how much you know, it matters to me how much you care about me. So I see you in the jacket, I assume that you know what you're doing. I assume that I've got faith that you're going to take care of me medically, but if I see that you care about me, then I feel just better all around.
Good point. The other piece about what Dr. Cangical had mentioned this is, I think we're trained, our brains are wired to seek out information and solve something. And sometimes we end up directing that interview or that discussion because we're seeking information to solve a problem. But sometimes you have to make sure that you've at least asked the question, is there anything that we haven't covered, or is there anything that you need to ask me? And sometimes we can get caught up in our own discussions, and sometimes we have to back off a little bit.
I think also recognizing maybe why, the purpose of some of the things that we will ask or receive. I've learned sometimes that patients will tell, me or the nurse something, not necessarily because they think we have a solution, but just to make sure that I know, or just to make sure, just in case it triggers something else. So I think on our part it's important to understand why you might share information and what you're really looking for from us.
So another comment actually from Jennifer Susi. Thank you for joining the conversation. She says, I cannot say enough kind words about Dr. Schneider. When I thought my life was at the end and there was no hope, he gave me hope and my life back. When there were a lot of uncertainties and fears, he gave me strength and courage, and I will be forever grateful to him and his amazing team. Thank you from the bottom of my heart. So my question is, how do you convince people to keep going when she says she didn't feel that there was any hope left? So you kind of wear many hats there and trying to...
Well, I think it does come down to that balance of being honest. When you discuss a diagnosis that sounds very daunting, and there are uncertainties, there are unknowns with treating cancer, that even now there's some things that we know in terms of what a prognosis can be and what the effectiveness of treatment can be, but there are still unknowns that we can't predict on an individual basis. And I think you have to balance that honesty with some hope that there is a likelihood and a probability that you can beat this. And sometimes if there's not that hope, if it's more about palliative treatment, we have to be honest about that too.
Did you guys ever see that movie? I think it was called My Life, and it had Michael Keaton in it. And he was diagnosed with cancer, I think at the beginning. And the one scene that always stuck with me was him just getting so angry at the doctor after an honest conversation. He said, you can't take away my hope. And when I read that, it reminded me how important that is. And you know.
I would say that it might not seem a natural thing, but oncologists by nature are absolute optimists. I mean, this is sort of the kind of people I think you have to be, right?
Yeah.
And even though there's a lot of sadness here sometimes, there's also, like I said, a lot of relief and joy and happiness too. So we see it all and we see the exceptions, and so I think that's part of that, where that optimism comes from, and then it just comes naturally out to our patients, and that's where I think the hope comes from.
So how do you deal with the difficult conversations then, and without kind of going to the extreme where there is no hope?
I think Ken said it. It's honesty. You have to just you have to share the facts. You know, the facts are very important to share. The reality of the situation is important, and then you have to allow the patient to lead you down that discussion, because everyone's at a different point, I think, in terms of what they're ready to hear. And maybe enough is enough for one day, but another day there's an opportunity. So I try to take my lead from the patient in terms of how much we might cover on a certain day or a time. And even in a terribly sad situation, I've seen so many people find joy and find closer relationships and find important time. So there's ways to find hope, but in a different way.
You know, there's something that we do have to deal with on a very regular basis in treating cancer, and that is advanced cancers that are incurable but are treatable. And it's striking that balance between what you can do and what's realistic to do. And you know, we should never, I believe we should never sit in front of a patient and say there's nothing we can do for you. I mean, that just rebounds in my head when I heard of that comment happening, you know, remotely in the past with a physician. I think, gee, that's something that just should never leave our mouths, because there's always something you can do in respecting that person's life and quality of life.
That's a good point.
That you have to acknowledge that and work within those boundaries.
I have a comment here from Jennifer. She says, Dr. Schneider included my son in the conversation and made it relatable at his age level. So that's probably important too. And when children are here, like you said, different cultures, it's a different message. You can't probably, there's not a template that you take into this room with you every time.
Is that Jennifer, the same Jennifer? Or is that another Jennifer?
I'm not sure.
Same, well, yeah, I know Jennifer, and on a patient-doctor basis, a wonderful lady and teacher, and would bring in her son in on occasion. We'd have a little chat. I still have the card that he painted, a picture on a card, and I still have it up on my desk. This is like 7 to 8, Jennifer, 9 years. I don't know what it is, but it's a long time. And thank goodness you achieved a cure, and I still have that. And thank you for saving my mommy's life. That's emotional.
So you must. I've got another one here, I think, that I'll bring up now, and it kind of touches on patients talk about when they leave the cancer center for their final time, and it's a happy experience, but they kind of feel cut off because they've developed these relationships. It's a place they never wanted to be, but then they've grown comfortable and they've developed those relationships. How do you feel when the patient is walking out for a final time?
It's a mixed feeling too, because you develop a bond. You know, the physician develops a bond with the patient and often with their family, and we're kind of part of the journey and some of the decisions and some of the highs and the lows,
and the family as well.
Absolutely. You know, sometimes, you know, a person's trying to get treatment so they can get to a wedding, or they have a goal in mind. You know, my first grandchild is going to be born. So, and you see them through those milestones, or you're trying to get to the end of treatment, or you're trying to get to that time when you can say I'm cured, or whatever that is. So, and sometimes it's a sad outcome, but you still have all those moments where you connect. And so when a patient is discharged, on one hand, it's the best thing, because nothing makes us happier than seeing a patient walk out of here not having to come back. Right. It really is a wonderful moment, and at the same time, there's a little bit of you that feels like, oh well, that's that's a piece of me that's gone as well.
It's an end, yeah.
It's an end. It probably is good to end in a healthy way, but there's still a little bit of loss that happens, I think, each time.
What kind of supports are out there for you guys who deal with the highs and lows, you know, in any given day?
That's an interesting question, because I mean, I'm happy to comment first. You know, we go about our day. It's what we do, and at the end of the day, when you take a deep breath and you think, okay, you know, you've done the things that you've hoped you could accomplish within the constraints of the day, and I think generally we feel good about that. But you know, we also have to realize that how do we carry that stress and that burden? And I think we all do it maybe differently. I don't think we talk about it very much at all. I think I have a concern with that.
Yeah.
Because where does that go? It maybe there's defense mechanisms. Maybe we get that stress out doing different things, sports or music or activities, time with the family. But it doesn't just disappear, or else you'd be pretty cold-hearted. It's in there somewhere. And how do we maintain our function and the job that we do, but respecting that we have to be healthy as well?
Yeah, I think that there's understanding more that sometimes we bury that deep, and it's not a good thing to do. And even at our center, we're talking a little bit about, you know, physician wellness and being able to speak to each other and debrief and pay attention to each other a little bit more, so that we keep each other healthy and well, so we're better for our patients.
It's important.
Yeah.
I think our patients do realize this, because they know the busyness of the clinic, and there can be delays, and every physician is different with the dynamic of their patient. And I tend to run over, and my nurse is looking at her watch, but she's amazing, the nurse I work with. But you know, the fact of the matter is we, and this isn't to be sympathetic to us, but our role, we literally have to focus on that patient, collect ourselves within minutes, and head to the next room.
The next one.
So, you know, that's a skill that I don't even think we understand.
Yeah.
You either can do it or you can't do it. You know, and maybe it's learned, or maybe it's innate, or both. But you know, you can't you know, go away and say I'll be back in an hour and pick up. You need to function during the day, and you have to make that experience best for every patient you see.
And I'll throw in a comment here from David Mouche. David is our president and CEO at Windsor Regional Hospital, and he wants to know, Ken, did you bring your guitar?
David, I forgot my guitar.
Of outlets.
I knew I forgot something.
You're live, Ken. This is the big moment.
Hang on, we'll go get it.
Maybe you can sing a little at the end.
That's right. Thanks, David.
I'll jump to a comment from Amy Brooks now. Amy, thanks for joining us. She says, Dr. Kanjikel is my oncologist. She is the most incredible woman I have ever dealt with my medical history. She has made my cancer journey incredibly comfortable with the care and compassion she has shown me. I feel blessed to have her in my life. She has a way of making you feel like you are the only one on the planet. People really appreciate that quality, I think. And thank you, Dr. Kanjikel, for saving my life and the continued support and care you show my family. This is a tough journey, and life after cancer is even tougher than the fight itself, but your compassion helps ease that worry.
Oh, wow. Thank you, Amy. Those are beautiful
That's the
words.
person we know, absolutely. Yeah.
And we talked about, you know, that first consultation, but she's talking about even life after cancer. So you still, what are the different challenges at that point?
You know, sometimes I always warn people, sometimes when you're in the midst of, say, chemotherapy, because I'm a medical oncologist, you know, you're just kind of fighting for your life and just trying to stay above water, come in every day, get your chemo till the next time you got to come. So you're just kind of actively busy, and you have a purpose every day when you wake up. And then when you've finished that portion of your treatment, sometimes people feel a little lost, because now what do I do? Okay, I'm done, so now I have to wait until I get to that magic 5-year moment, right? And so it's a tough transition. I mean, they're of course relieved not to be getting that difficult treatment anymore and having to come in and have labs and all those things. But there's a different type of worry and heaviness that comes sometimes with not having that constant touch anymore.
Point.
And that constant back and forth, because then there's the worry that comes, and then there's the waiting to see, am I going to recover? How much am I going to recover? Am I going to get back to where I was? And then things that you didn't worry about before, suddenly you worry about. So there's all these games that I think come along that you, with your mind and your body too, that you have to deal with. Yeah.
One thing that I think about a lot when we talk about discharging patients back to the community and their community physicians, which is happening earlier and more commonly now for the right reason actually in cancer programs, whereas traditionally we follow people for not only 5 years but even longer than that. And when you really look at the evidence behind that, it's pretty minimal in terms of what true value that has, unless you, for specific cancers it's important, but not for all cancers. And I think we all have to realize that we've got a wealth of experience in the community with our family doctors, and it's about shared care. And even though I think it builds a comfort level for patients to come and see their oncologist for a checkup, there are things that trained physicians do very consistently. And it's about building that relationship back with the family doctors as well for follow-up.
Mm-hmm. A question from Karen. Karen, thanks for joining us tonight. She says, in the world of Google, what advice do you have for people who are newly diagnosed and then turn to the internet? You probably don't see that often.
I think it's the natural thing to do. If I've got something, I go on the internet and check it out. So I think it's the natural way. And I think as docs, we expect it. It's not a surprise anymore. Maybe 10, 15 years ago, it might have been a surprise. So I think it's common. Well, I should say, there's some folks that come in and they're just like deer in headlights. They just kind of walk in, they put their trust in you, and you do your very best, and you recognize that responsibility. Others will come in with some information. They've done some research trying to get a sense of where they fit in all of it. But they're warned also, don't go too much because don't look too much because there's so many rabbit holes you can go down when you're on the internet, right? And then there's others who are maybe in their own jobs and their other lives, their job is research and understanding, and they're very, that
problem
kind
solvers
of
as well.
Yeah. And so they'll come in with a different perspective and a different way that they've researched and understood their problem. So I think people use the internet resources differently, and our job is to kind of meet them where they are and either help them to use it more efficiently, so maybe send them to sites that will help them to get further along in their education, or steer them away from potholes that you could fall into easily if you just kind of follow the usual way. There's a lot of misinformation out there, but a lot of excellent information too.
Do you ever have people that no longer trust what you're telling them because of something that they've read online that they're pretty sure is the answer?
I don't think they don't trust. I think they want to ask the question. So maybe they read something and it doesn't fit with what they've heard or what I've told them. I would always say, come and ask me. And then it rarely is a mistrust, but more of an understanding. Okay, well, why is that? And then I'll give my opinion about whether I think that's accurate or inaccurate, and then people can make their decisions.
It's more about, I think, the interpretation of the information they're reading, make sure that they understand it. So I tend to tell my patient or their families that if you read something that you're uncertain of or that's unsettling, that you don't understand, bring that forward so that we can maybe clarify that, because it's surprising what they may read may be misinterpreted and can be very daunting and stressful, and it's not part of their scenario.
We had a few questions about switching doctors. Is that ever okay? And what would be some of the circumstances that you could or would consider doing that?
So that happens every so often. I mean, just like in any human interaction, sometimes you just don't put it off, or you don't make that strong connection that you're hoping for. It's not a very common thing, because I think we are lucky to have very wonderful oncologists here. But sometimes it happens, and then there is a process at the Cancer Center where you can talk with one of the managers, and they'll usually talk to you about, what's going on, what's your reasoning, what are you looking for if you are looking for a different oncologist, and they can help you. So if that is what you want, it's possible. If it's just a different way that you wish to be, addressed or just something discussed, then sometimes that first oncologist that you have the initial relationship with is actually the real one that you want to stay with, but with just a little bit of a better understanding of how that relationship can go.
Okay.
So you have options always.
Dr. Kanjiko serves in the role as chief now, and I came out of that role, and one of those jobs that we have is to try to help resolve those things. If there's a scenario between a physician and a patient where the dynamic is off and it raises some concerns, you first see if something is correctable, because it can be a strong relationship still, and you can get it back on track. If that doesn't happen, then it's reasonable to consider a switch to another oncologist to just make that more productive.
A question from Bonnie. Bonnie says, why would an oncologist get upset when a patient seeks a second opinion? And not suggesting that you would, but I think maybe a fair question is, what do you think when a patient asks for a second opinion? Is that fair?
Well, is that okay?
You can start, yeah.
I guess the request can come in different forms. So one thing that can be offsetting to, first of all, I think fundamentally that patients have a right for a second opinion. And then it's a question of what's the context of the request. And it can be unsettling sometimes, and this doesn't happen very often, that if a patient comes in and almost right at the get-go, they're asking for a second opinion, and you haven't even had the discussion as the first opinion. That can be unsettling for the physician. Personally, I think that, and you want to get them to that point where first they understand what's involved in the consultation and how you can help them, and then if that leads to a request for a second opinion, then we try to respect that. Some second opinions we actually want to seek out for our patients because we want that additional level of expertise on a challenging diagnosis. So we would request that, and that's really the fundamental nature of multidisciplinary case conferences now, where physicians get together from all different expertises, and we form a consensus on a treatment plan that is evidence-based and is consistent with the standard of care.
That's interesting, and I think that's interesting for people to know. Kind of, can you tell me a little bit more about those discussions?
So they're called MCCs, multidisciplinary case conferences, and they're very strongly supported by Cancer Care Ontario, and they really serve an important purpose because, as we all know, oncology is very complicated, and it usually involves a lot of different specialties, complex imaging, pathology, and then a number of subspecialists who all need to get together and come up with sort of the best strategy for a patient. So it's complex. And sometimes it's straightforward and, the evidence is clear, this is the best way forward. Other times it's not so clear and the pathology is complicated, the imaging is difficult to interpret, and sometimes there's even different ways to manage the same problem. So these conferences happen there's probably 6 or 7 every single week, and we all go to them depending on our area of specialty. And it's an opportunity to talk about those cases. Like if it was my case, I would bring it up, present it, and then get everyone's input and opinions. And so then when I go back to my patient, I can say, hey, I was in a room with a dozen doctors. We all looked at your case in a very fulsome way, and this is what we recommend. And that gives us a lot of confidence too, especially in a difficult case, to say, we've actually been able to get multiple opinions. Then if a patient still wishes to have a second opinion, I think any good physician will say go, because in the end, I want that person to come back and feel confident and to feel, okay, I've done my due diligence, I know what all my options are, I've heard it a couple of times, I'm ready to go. And then it's always a good relationship that always gets better.
And your goals are all the same, right?
All the
Everybody
same.
in here, the goals are the same, and I think that must be comforting for patients to know that they may be sitting in this room with you or with you, but it's a team approach.
There's a room. There's 10, 15 people behind you.
The other piece that people that haven't been trained in science or in scientific methodology, that when we recommend treatment based on certain evidence, there's different levels of evidence that physicians have to review to base their decisions on. And there's a real hierarchy of that level of evidence. Now, people wouldn't generally know that unless you read about it, but there's very high level evidence that we can make very good kind of recommendations on, and then there's lower levels of evidence, with the lowest being just expert opinion without good studies. And you'd be surprised in medicine how few decisions in medicine are based on really, really high level evidence, but we have to use what's in our means, and that's why these multidisciplinary teams are so important, because you can discuss this with your colleagues and gain their experience as well.
What about if a patient sees something about an alternative therapy? How do you approach those discussions? Kind of the other extreme there.
That's becoming a much more common phenomenon as well, compared to say 10 years ago. And it's tough because, as following on Dr. Schneider's discussion about levels of evidence, as physicians, we're very much driven by that, and we're looking for the best evidence that we can. And in general, alternative and complementary therapies, the levels of evidence are lower. And so then we're left with what we do with other patients, consensus, what's reasonable, is there a kind of a biologic, rationale for something to make sense. And so every oncologist, I think, also has a different perspective on it slightly, and I would suggest that every patient should, number one, talk to their oncologist, be open about what you may or may not be wanting to try, what you are doing.
Because I'm guessing if they're going to try it, you'd rather know.
Absolutely, yeah, absolutely. Just if you let us know, then I can give you my best opinion about it too, and then in the end you can make the decision: is that something that I want to take or not take? Sometimes I'll actually say I'd rather you not do it during chemotherapy, but maybe afterwards. That's why it's good to be open about what you're doing.
This is a similar question to what we had been talking about with second opinions, and this one's from Jane. Jane, thanks for the question. She says, what is a patient to do when they go to two different cancer centers and they give you two exact opposite treatments? And she talks a bit about her niece who had gone to Carmano Center in Detroit and also to a facility in Toronto, now has two different opinions to think about that are very different. What would you advise a patient in that situation?
Well, I'd probably like to see the clinical notes and the recommendations and what they're based on, and then I'd probably look at what levels of evidence those different recommendations are based on. And it may be that based on that particular diagnosis that there isn't one standard of care, and that's why a patient is getting different perspectives from different physicians.
There are different ways to treat.
Yeah. Absolutely. It's always a highlight, especially when you have group discussions. You can have two or three very good, solid, different ways to treat the same problem, different approaches. So sometimes there isn't just one correct answer.
I think you guys have been getting a little bit of love on online while we've been talking here, and I just want to, I think we're starting to wind down here, but if you do have any more questions, please send them before we wrap up. We've got a comment from Gail. She says, listening from
Houghton, Michigan?
Houghton, Michigan, in the Upper Peninsula. Hi, Gail. Thanks for joining us tonight. Sandra says, Dr. Schneider has been a godsend. He takes his time to answer all questions. He's the only doctor that listens to my concerns. The listening theme is huge.
Thanks, Sarah.
A comment from Diane who says, Dr. Schneider saved my life. He is compassionate and very caring. He spent a lot of time with me when I really needed it, so thankful for him and all of the oncologists at Windsor Regional Hospital.
Very sweet comments.
You guys do play such a huge role in people's lives, and I think that there's a lot of appreciation out there. Obviously, we saw it. I was talking to, again, Dr. Ham the other day. Dr. Ham is an oncologist in our center here, and she had just won the Human Touch Award and talking about what it means to have the human touch, and I think that listening was a big deal. Dr. Ham's also of researcher, and she talked about. I said, so how was your day? And she said, the smile, her face lit up. I just found out that we were approved to use a new drug on a patient, and I think that that's really going to have a big impact on this patient. And just like the smile made me realize how much you guys really do feel connected to the job that you're doing and the impact that it has. So my final question for tonight is one that I learned from you. Is there anything else you think that we should talk about?
We could keep this going for hours, I'm sure.
I bet there are a lot. Anything else that you think is important for patients to know? How to best prepare to come in here and talk to you guys. Pretty easy to talk to so far, but I'm sure that every conversation is different.
I would just say it's a short time that is technically allotted, although many times it's longer and shorter depending on what the need is. So when you're coming in, I think if you can prepare to kind of take advantage of all your whole team. So in almost every case, you're going to have a clerk, a nurse, and a physician that you'll see. So I would encourage people, think of what do you need from that clerk, the one who does all your scheduling and make sure you get your lab work done and get the questions you need from her. And then take advantage of your RN because she's a wealth of information. Just got so much knowledge and tricks and can kind of help you kind of navigate in many ways. And then when you meet the oncologist too, if you can sort of be thinking of what are the really important things that you want to walk away from on that after that visit, that'll help you to walk away feeling like, okay, I got what I needed, and you didn't walk away feeling frustrated.
We cover so much information during a consultation visit or a follow-up visit to discuss the treatment plan that sometimes it can be information overload. So I think it's sometimes a real balance for the physician to not give too much information, but still need to give the information that's necessary to have the patient understand. And sometimes that can be done in one session. Sometimes I think we have to appreciate that has to flow into another discussion if you want to really do the best that you can for the discussion.
Well, thank you so much for joining us tonight. I don't know how much time you guys actually do allot for your appointments, but I'm sure that we've gone well over that time schedule. So thanks very much. This is our last Cancer Center Live chat of the season, so I really appreciate having you both in. Thanks to all of you who joined the conversation as well today and throughout this season, and I hope you have a wonderful summer and an excellent night. Cheers.